o'clock, and it is day 4 at TCT 2015, and lots have happened. I'm doing this for On the Scene, and you know, time flies so quickly, it feels like only yesterday we were wrapping up day 1. And so here we are at the end of TCT, and I am trying to get to the sort of nuts and bolts of what we learned today. We've got 2 studies that are important. With me is Deepak Bhatt, my colleague and friend and mentor. Deepak, we have SAPIEN 3. Let me just quickly say a couple of words because I think we can finish this off fairly quickly. SAPIEN 3 is the 1-year follow-up of the transcatheter aortic valve replacement from Edwards. Approved device at 3 months because the outcomes were so good, particularly in terms of paravalvular leak. The new device has this skirt around the bottom which really diminishes paravalvular leak. It is user-friendly, easy to use. We knew that from the 3-month follow-up, and now at 1 year we still see very little paravalvular leak. There is some mild, but interestingly, mild paravalvular leak does not correlate with an increase in mortality outcomes, which is a real change.
Yes, that is.
And exactly why that should be, I'm not quite sure, but I guess it is just better sealing.
Right, and I thought the other interesting thing was the low stroke rates, right? So that's really pretty impressive, and I think just shows the evolution that's occurred in TAVR.
Couldn't agree more. So TAVR is now, I guess, really moving into the lower range of STS score patients. My guess is, as in Europe, we're going to see a lot of patients who are much better candidates for TAVR who are lower STS scores, and we're just going to move into what the surgeons have also always considered to be their property.
Absolutely. I don't think any place in Europe is doing octogenarians with conventional surgery anymore, right? So I imagine we'll move to that same position in the U.S.
The issue, of course, still being the bicuspid valve and the very young patient, and whether you want to put a tissue valve in a young patient, but those are issues that for further trials, I guess.
Absolutely.
Yeah. Okay, so I'm going to turn the podium over to you, Deepak. Bravo 3.
Right, I thought a really important and well-done trial of patients, again, undergoing TAVR, although this time the question isn't the valve, but the optimal anticoagulation strategy, heparin versus bivalve, the thinking being that a number of studies have shown that bivalve is associated with less bleeding, so, you know, sticking large French catheters and sheaths into the groins, you'd think maybe bivalve would shine particularly well, so a very reasonable hypothesis. So patients were randomized to one of these 2 strategies, and you know, for the overall primary endpoint there ended up not being any significant difference between the 2 strategies. Maybe a little bit of a surprise, at least for me, because I was thinking bivalve would reduce bleeding.
Yeah, I think it's a little bit of a surprise too. I mean, from the stent world we've been taught that bivalve reduces bleeding. Now there are some new studies coming out saying, wait a minute, we're not quite so sure. And the difference in cost being a real issue because bivalve is more expensive.
All right, though it did just go generic, so the price is dropping and will continue to drop.
Hopefully that will be true. That will make it a little bit more even, but heparin's still pretty cheap.
Yeah, it'll be hard to beat the price of heparin.
And the nice thing about heparin is it can be reversed.
Yeah, you know, one thing we didn't know about this trial because it wasn't in the presentation or paper because they didn't capture it was what the use was or wasn't of protamine. So we know what happened in the bivalve strategy. They got bivalve as the protocol said to, but in the heparin strategy could have been some places giving protamine. So we don't really know what the comparator arm was. Do you reverse your TAVRs, by the way?
Yes, we do.
See, so there's probably a fair amount of variability in terms of places, whether they do that or not. So I can see how bivalve might not beat heparin if you're reversing with protamine.
So for TAVR, bivalve and heparin, no difference in bleeding outcomes, just still difference in price. But I think one of the messages out of this trial, even though you sort of might say it's disappointing, is if a patient can take heparin, bivalve is a very reasonable substitute.
Right,
so
if they've got HIT, for example, or a question of thrombocytopenia or something.
Exactly, but the HIT patients are not a minor issue if somebody has HIT. So I take away some positive things from this trial.
Did you think the difference in MI was a real finding? If you recall, there was a p-value of less than 0.05 for MI in favor of bivalvutin versus heparin.
Yeah, I'm not sure what drove that or how that happens. Do you have any ideas?
Well, yeah, I can't say from the trial itself, but you know, it was recently reported. I actually was a co-author on a paper in NEJM about subclinical leaflet thrombosis that was observed on 4D CT and TE. So it's conceivable there's a little bit of thrombus forming here and there.
That would make it embolic infarct, and I guess that's still possible. Certainly.
I'm just
rare, but happens.
Yeah, I mean, I'm just throwing stuff out there. It doesn't
reasonable.
always stick, you know. But
that's why you're my mentor. Okay, so there we have it for day 4 here at TCT. A final wrap up. Thank you, Deepak, for doing this with me.
Thank you, Peter.